Okay, sounds like the mic's working. Hope you don't mind. I tend to like to walk around a little bit, hence the lapel mic. And I'd like to thank David and the college for asking me to talk today. A lot of my colleagues sort of think that was a bit crazy doing a PhD in syncope, because it's sort of quite a challenging area and an area from which a lot of cardiologists kind of run and would prefer to be in the lab doing more procedural work. So I've got a sort of, I guess, a series of cases and things that I thought I'd run through as a way of talking about issues in this space. I am, as David said, an adult cardiologist, so this is focused on adult syncope. So the first thing to sort of ask yourself, I guess, is what the definition of syncope is. And syncope is a transient loss of consciousness, so it falls under that general umbrella. It's rapidly reversible, and usually minimal sort of intervention is required to do it. And it's typically due to a reduction in cerebral blood flow, and that's primarily driven by a fall in blood pressure. The definition is important because it's not uncommon that people fail to discriminate different causes of transient loss of consciousness and tend to sometimes overlay syncope, seizures, collapses, and various forms of altered conscious state and tend to merge it into one. So syncope does have a fairly strict definition. So looking at epidemiology, vasovagal syncope still dominates as the #1 cause of syncope across all age groups. So you can see that it follows essentially a bimodal age distribution. So more common in teenagers, early 20s. That's certainly a group that I see. And then from the 5th and 6th decade onwards, again, escalating in incidence. And with our aging population, we're going to see more and more patients presenting at that latter end of the spectrum. So there's a range of diagnoses that one might think about. In the younger patient, we get worried about whether we're missing more sinister pathology like long QT syndrome or Brugada or something that might cause sudden cardiac death. And in older patients, it then becomes an issue again of are we missing or going out and looking for significant cardiac pathology, whether it's arrhythmias or ischemia, pulmonary embolism, whatever it might be, depending on the clinical scenario. So I always play this video at pretty much all my syncope talks. So this footballer has died, unfortunately, on the soccer field, and typically we'd all sort of see in the media reports of people dying during sporting events at a young age. And whenever you see a patient with syncope, the first thing that comes to mind is risk stratification for sudden death. This is an algorithm. There are many of these algorithms looking at syncope, but the crux of any algorithm is risk stratification. So at the beginning, there's clinical history, which I can't emphasize enough is a critical component of your assessment, physical examination, obviously, and the 12-lead ECG, along with blood pressures, forms the cornerstone of assessment. And you can get the vast bulk of the data that you need to work out a potential cause in your patients by spending an adequate amount of time doing that. And then it comes to this key sort of dichotomy of working out whether your patient with syncope is somebody at low risk of cardiac syncope and potentially sudden death, or whether your patient is a high-risk patient. And rather than creating grey zones and so on, I think it is better to follow this sort of algorithm and think in a fairly dichotomous way. So risk stratification of syncope involves assessing a patient's history in great detail, working out what the situation in which the syncope occurred. Did it occur with exercise? Is there a good trigger for it? What their background history is. Do they have a history of sudden cardiac death? That sort of thing. And then obviously looking at findings on ECG. Now, I've sort of listed a whole series of ECG findings there. And in essence, what I've kind of done is listed just about every common ECG abnormality that I could think of and fit on the slide and be vaguely legible. And the idea there is to basically tell you that any abnormal ECG should be a red flag in a syncope patient, raising the possibility that you could be dealing with a cardiac issue. So, in essence, to stratify a patient into one of these low-risk categories, you need a history and so normal physical examination, but a history that is consistent with vasovagal syncope, so a typical story, and we'll talk about what that typical story might be a little bit later on in the talk. You want to see a plumb normal ECG, and in that sort of setting, you would define the patient as low risk. Anything potentially outside of that, you would probably classify as high risk. So we'll start with a couple of cases then. So this is a young chap, an IT professional. Flavour of the talk, they're always playing sport. I don't know why I've done that. But anyway, playing sport, has a syncopal event on the football field. Is not particularly keen in getting assessment, which is not uncommon, of course. No significant past history. There's no history in the family of sudden cardiac death. And that's quite important. But on examination, of course, you've heard a harsh systolic murmur. Does anyone want to shout out what they're thinking? Yeah. So abnormal ECG. Thoughts on the ECG? You can just shout out, I don't mind. Yeah. What else? Oh, sorry. So he's saying hypertrophic or obstructive cardiomyopathy. And then we're saying large complexes. I couldn't quite hear that either. Q waves. What about the T waves? Yeah, so the big sort of jump out abnormality is the big sort of T wave inversion. Could be left ventricular hypertrophy in an older person. You might be thinking about ischemia. But of course, in this setting, in a young person with a harsh systolic murmur, we're thinking about hypertrophic cardiomyopathy. So the echocardiogram on the right shows a normal, on the left of your screen obviously shows a normal left ventricle. And if I can pick the laser, there we go. So this is the left ventricle here. This is the mitral valve, the aortic valve, the aorta coming out through there. And up the top here is your right atrium. We call this the right ventricle rather. So this is what we call the parasternal long axis view. And as you come into this one, you can see that the septum is markedly thickened, which is typical of hypertrophic cardiomyopathy, at least of this particular pattern. And if you look very closely at the movement of the anterior mitral leaflet, you kind of get the sense that it's kind of, there's motion of the leaflet into the outflow tract with systole. And that's what you sometimes see on reports when a cardiologist reports back and says systolic anterior motion. And it's part of the obstructive process that causes the high gradient and the murmur in hypertrophic obstructive cardiomyopathy. We get worried about sudden death in this setting, particularly in patients with syncope, and that's at the bottom was a representative sort of Holter or ECG tracing that basically showed ventricular tachycardia. So risk stratification of hypertrophic cardiomyopathy is challenging, particularly in people that don't have a history of sudden cardiac death, but any patient who's got HOCM and an episode of syncope would be regarded as at elevated risk. Other factors that play in would be the thickness of the septum, so massive septal hypertrophy, for example. Anybody with a family history of sudden death would be at higher risk. Lots of ventricular ectopy or runs of VT on a Holter monitor, and falls in blood pressure with exercise is also important. But it's complex. But the upshot is, from a sort of take-home message point of view, is this question of, is this patient at risk of sudden cardiac death? Do they need a defibrillator? This sort of patient clearly needs expert assessment and a determination of that to try to mitigate risk. Is that a question? Yeah. That is also a take-home message. Yeah, and that's a message you'll see in a few of the other slides as well. That exercise-induced syncope is extremely abnormal when it occurs during exercise, not when it occurs post-exercise. So second case, so this is another, I guess it's another exercise sort of syncope. So an older chap, I saw a case just like this not that long ago, walking sort of up a gentle kind of hill, had a syncopal event, and was referred in for assessments, got a harsh systolic murmur. Diagnosis? Stenosis, yeah. So that's the same ECG pretty much, isn't it? Oh, very similar, T-wave inversion, left ventricular hypertrophy, and that's a normal echo, which you've seen already. That's a typical sort of echo of somebody with calcific aortic stenosis with a calcified aortic valve that doesn't move very well. And again, if you're risk stratifying, as you've said, exercise-induced syncope, that alone should be a red flag as being very, very abnormal. And in the presence of aortic stenosis, that's a significant prognostic marker for a poor outcome without intervention. And this slide from Up to Date sort of highlights that quite nicely, that the moment a patient develops symptoms with aortic stenosis, particularly exercise-induced syncope, it predicts a high mortality, and from my point of view should be regarded as a relative surgical emergency that needs to be fixed. So we grade severe aortic stenosis based on a valve area under 1 square centimetre, a mean gradient over 40. There's a range of other echo parameters, but in essence this patient should be seen fairly promptly, and almost pretty much most of us have had patients that certainly end up dying on waiting lists for surgery, which can be very unfortunate. Oh, come on. Oh, we're not moving. There we go. Okay. Next case is a little different. So here's a person in their 60s who's had some vague symptoms, felt a little bit unwell in the morning, some sharp sort of chest pain, a little bit non-specific, but generally not feeling quite right, and so called the ambulance or went to an urgent care centre, however you want to write it. Past history of mild Parkinson's, bit of hypertension, maybe some COPD, on a few stock standard medications. And when it arrives at either the clinic or the emergency setting, went off to the bathroom and had a syncopal event in the bathroom, and was noted to have some jerking movements, was rushed back to a cubicle, lie down, and by the time sort of all the basic obs were done, blood pressure was sort of, I guess, relatively normal, and sats were pretty good and looked relatively relatively stable, and he recovered quite rapidly. That's the ECG from this patient. Any thoughts about that? Brugada, yeah, not really criteria. What's the rhythm? Is it regular or irregular? It's irregular, so it's AF, and it's a right bundle branch block pattern ECG. So has some investigations done. And do you guys use high sensitivity troponin here now? Is that norm for you guys?
Just in the hospital.
Just in the hospitals, okay. Yeah, we're a pretty mixed bag in Australia as well. So slightly elevated white cell count, slightly elevated high sensitivity troponin, nothing much on a monitor. So I just put these kind of MCQ type points just for a point of discussion, but interested in what people would do at this point. Any thoughts from the floor, or? Are you missing a P? It's a good question. That's a very reasonable diagnostic thought, particularly with a right bundle branch block and with sharp chest pain. I think that would be a very reasonable thing to look for. Is anybody bothered by that troponin elevation, or don't care, or? Sure. Would people end up anticoagulating for non-STEMI or not, or serial enzymes? Okay. Okay. All right. Well, let's see what happens. So I'll just talk for a moment just about troponin assays. So there are a range of assays that have obviously been developed over time. Low sensitivity assays were the original sort of contemporary ones, and then the sensitive assays came out, and the high sensitivity assays came out. The high sensitivity assays essentially pick up, typically it's 90-95% of people should have some sort of detectable level of troponin. So I should have one, you should have one, and if I go run a marathon, I should have an elevated, highly sensitive troponin. The key thing in discriminating as to which assay you've got is the unit. So nanograms per litre is the unit for a high sensitivity assay versus milliliters, which would be a sensitive assay. And this graphic is put up quite a bit when people talk about troponin, and it gives you a sense of the diagnostic categories that people might fall into as they have a rising high sensitivity troponin. So remembering that the troponin assay is not a positive or negative test, it's not a pregnancy test, so you're not pregnant or not pregnant, or it really is a probability game that is merged with your history, your ECG, and your general assessment in terms of what diagnosis they've got. And this table from the ESC, sort of chest pain or whatever it was, ACS assessment, reminds us of the large number of diagnoses that will elevate a troponin. And in the era of high sensitivity troponin, even more sort of things that are going to have particular. Similar one to the, it's not the actual case, but it's a very similar one. So interested in any comments on the chest X-ray? I assume you guys have to... Yeah, enlargement of the aorta has been suggested. It's interesting. It's certainly ectatic and a little bit unfolded. I did run it past a radiologist. I wouldn't claim to be an expert at reading chest X-rays anymore. And he sort of shrugged his shoulders and kind of said, well, you know, pretty borderline on that, and maybe unfolded, wouldn't take too much heat of it. And of course, this patient did indeed have an aortic dissection. And in fact, that chest x-ray came from a coronial case for a patient that had a missed dissection, and the chest x-ray is certainly regarded as being relatively normal and not supporting of that. The message, I guess, is that in studies, syncope can be a presenting feature of 15% of aortic dissections. Aortic dissections particularly present atypically. I had a lady walk into the rooms 2 weeks ago with some atypical, I think it was a soft murmur, and otherwise feeling relatively well, and we were just asked to do an echo, and she had an aortic dissection. And I rang her up at home asking her to go to hospital, and she said, oh, I gotta go visit my sister in the country, and can I go tomorrow or maybe the day after? It was impossible to convince her because she felt perfectly well. Of course, she finally went 2 days later, had the CT, and had a type A spiral dissection. So always keep it in mind. So I'll move away from these higher risk group for the moment and talk a little bit about vasovagal syncope and some related conditions. So here's there we go. Okay, so here's a 26-year-old lady. She's a young lady, otherwise fit and well, traveling on the train, felt lightheaded, nauseated, a bit dizzy, typical sort of vasovagal story, had a collapse, and was helped by her bystanders, but of course she's in a public place, so an ambulance gets called. And on the ambulance note and from the bystander history, there are comments that when she hit the deck at the platform or whatever it was, that she was getting sort of these fitting and jerking movements, and somebody thought she'd had a seizure for sure. And there was comments about not really feeling a pulse at the time. But she's basically going, I want to go home, I feel perfectly fit and well, I'm sure I just had a faint. She's alert, she's orientated, normal examination, and that's her 12 lead. Just interested if anyone finds that interesting or not really bothered, or can't hear you. No. Sorry, no. Yeah. So she's in sinus, and she's got ventricular ectopics. There we go. Ventricular ectopics. It's otherwise a relatively normal. This is a relatively normal ECG. So sinus rhythm VEs. What did people think of the story? Typical for a vasovagal, or don't like the fitting and the witness story? Show of hands, who thinks it's a typical faint? Hands up. Who thinks it's something else? Okay. All right. So she does have a fairly classic, very classic, typical story. So the right situation, the right circumstances, the right story. We'll think about the bystander component, but the risk profile overall, with essentially a normal ECG other than some VEs, is a low risk patient. The question is whether that fitting stuff and not feeling a pulse and all the rest of it is significant. And so it brings up this issue of how do you discriminate sometimes between a seizure and a syncopal event. So seizures, in particular, things that really jump out as being neurologic would be people who've got visual, auditory hallucinations, sense of déjà vu, a more prolonged recovery phase or post-ictal phase. And in the syncope space, the seizure activity tends to be much more short-lived. They can certainly get myoclonic and tonic myotonic sort of jerks due to the cerebral hypoperfusion. In fact, there have been studies where they've done video EEG monitoring of people with syncope and people with seizures, given the videos to groups of neurologists, and they have a great trouble discriminating which one is a seizure, which one is syncope, purely on the appearance of what happens. Urinary incontinence can certainly happen during vasovagals, as most of you would probably know. And so that idea that that's a discriminator is sort of untrue, and again comes back to that key sort of story and history fitting with the original diagnosis.
So here's a healthy, normal German medical student syncopizing away. There he goes. He's taking a little longer than usual. There he goes. I want you to watch on each of these patients what their movements are like. So he's shaking. That's the myoclonus that reliably accompanies somebody who has transient ischemia to their cerebral cortex, or it may be the basal ganglia, we're not really sure. So she twitches a little bit. Those are fine examples. But you say, I can tell the difference. Well, you tell me if you can tell the difference between this guy. Watch this. Watch these movements. If you're seeing this yourself in the emergency department, I would argue this would be difficult to distinguish from a generalized tonic-clonic seizure, let alone if we're asking these patients' family members who are freaked out. Watch her. She's my I mean, this is a normal person. This is you. You can do this too tonight.
So I actually don't know who did this video now, because I found it a few years ago. And so if anybody ever knows, I humbly sort of acknowledge that it's yours, and it's been really helpful. I do a lot of tilt table testing, and I see this quite commonly. And so it is hard to tell. And you can imagine what a bystander, what a family member is going to describe. And it went for hours, doctor. Such a long time. And nobody has a sense of time during a crisis. So I think, yeah, bear all that in mind. So I want to move on to another case, which is really looking at this concept of unexplained syncope. And I specifically talk about that as a distinct group. There we go. Okay. So here's a chap who's had a single syncopal event. There's no good story. There's little memory of the event. I collapsed. I don't really know much, doc. The exam was normal. The blood pressure's normal. Nobody witnessed it. Examination's pretty normal. CT brain is normal. Bloods are normal. The ECG's normal. We all see this, right? Had a blackout. Can't tell you anything useful. So, you know, what do we do with that? So, it's quite tricky. There is certainly a feeling that you probably need to look into it a little bit more and try to work out if there's any sort of sinister pathology going on. I think as a patient gets older, look at their overall risk profile, general risk factors. Most of us would probably investigate more aggressively for underlying cardiac disease. And one of the things to remember is that in somebody who's got unexplained syncope, particularly once it becomes recurrent, the probability that you're going to be dealing with an arrhythmic basis for these events is up to 50%. And the yield for monitoring is often very, very low. And these patients can often benefit from implantation of a loop recorder as part of their long-term investigation. So 24-hour Holter monitors have a low yield. Generally, if it's been immediately post-event, that's often the higher time that you might pick something up, but the data in that is not robust. But it'd be very reasonable to, if that patient had had an acute event, to at least monitor them for 24 hours along with your basic sort of cardiac workup. Why is that blank? So, yeah. So we can sort of take the vasovagal group and break it up into three sort of components. One is the classic vasovagal syncope, like the girl on the train. Atypical forms where you go through a process of excluding other things. You might replicate events with a tilt table test, something like that, and you form a diagnosis. An unexplained syncope, which is a different beast, where everything is negative and you're really not any the wiser as to what it is. It's just really important not to put that down to a vasovagal, but to realize that you could be dealing with a arrhythmia, particularly episodic AV block. Questions? Yeah.
So we mentioned everything about dehydration, all this. What about hypoglycemia?
Sure, that's a metabolic cause of transient loss of consciousness, though, not a cause of syncope. Yeah. So it was just a question about hypoglycemia, and just again making the point that that's metabolic, that's not cerebral blood flow, and it's a transient loss of consciousness diagnosis, not a syncope diagnosis. So here's another young person who had a syncopal, pre-syncopal event at the photocopier, felt dizzy, lightheaded, because she was at work, OHS, they called the ambulance, she got carted into hospital. It's got a past history of Hashimoto's, thyroiditis, no family history of sudden cardiac death, is otherwise fairly well. We'll assume thyroid function tests are normal. And arrives, there's nothing much to find on exam, ECG is pretty normal. She's keen to sort of go home, she's had a few hours of monitoring. And when she gets up to sort of leave the department, she feels dizzy, lightheaded, and becomes sort of tachycardic, and goes and lies down again, and the nurse does an ECG, and it looks relatively normal. Interested in thoughts about that? Yeah, so quite suggestive of POTS, isn't it? Makes you sort of wonder about that. So I'll skip that would you do stuff. So patient gets, not uncommonly obviously, these patients sometimes, particularly when they present more acutely, really struggle to sort of go home, and they not uncommonly end up getting admitted. And it's also not uncommon, of course, that they go through a workup and they might get a septic screen, and somebody might think they've got a PE, and they get a CTPA, and they get an echo, and so on. And all of that may be very, very reasonable, screening for PHEOs and checking their thyroid and so on and so forth. Postural blood pressures are very important. Generally, postural tachycardia syndrome patients should not be hypotensive. They're usually normotensive or hypertensive, along with the tachycardia. And so this is kind of my schema, I suppose, for POTS. But in essence, a heart rate rise of sort of 20 to 30 beats per minute over baseline on standing, or sustained for more than 120 beats per minute, and it needs to be sustained. So it's not just the initial rise. You've got to stand these patients for at least 5 minutes and see what happens over that time. The constellation of symptoms for POTS patients is myriad. There's often an overlay with chronic fatigue, depressive illness, anxiety disorders, irritable bowel. They often get heat intolerance, complain of brain fog and difficulty concentrating, and are an incredible challenge to manage. And I sort of set up a schema of sort of disorders of circulatory control. And so you've got patients with vasovagal syncope, patients with POTS, patients with autonomic failure, and patients with initial orthostatic hypotension, which is a transient fall in blood pressure that people get for a few seconds on standing and is regarded as a normal variant in blood pressure fluctuation. So it's the sort of person that will go, oh, every time I get up I go black and it goes grey and it lasts a few seconds and it's gone. Something wrong with me. And almost always they've got IOH, initial orthostatic hypotension, and it's a normal subset of the population. So that's POTS. I'll move forward because I think we're running short of time. So I've got a couple of last cases, and then obviously happy to chat further. But here's a 70-year-old patient who's had a syncopal or a few syncopal events. And doesn't really get any warning about what happens, and in fact had a laceration to his head, skull, about 6 months earlier following a collapse. Got a past history of hypertension and is on a few antihypertensive pills. Obviously, we'd get a little bit concerned about the hypotension drugs, and maybe there's a component of postural hypotension or drug-induced pathology. But here's the ECG. So again, what do you guys see on the ECG? Left bundle branch block, sinus rhythm, left bundle branch block. So taking it a step further, recurrent syncope, ECG with left bundle branch block. Thoughts about diagnoses or actions? Is it new? That is a really, really good question. Let's assume we don't know because he didn't bother to present for the last ones. Okay. Why would you admit? So presumed new and admit.
For further run, he needs drops, he needs echo, he needs just X-ray.
Yeah.
And the whole point is to find out why he's having these symptoms.
Sure. What would be, so you want to admit, do a whole lot of tests. Would you have a particular sort of, let's assume that his echo is normal, has got a normal set of bloods, and he's not, let's assume that he's presented to you after the syncopal event a month later. So we're not talking about an acute, let's assume it's not an acute event. Any further thoughts on diagnostics or what people would do?
Check on congruity, whether ST and left bundle are congruous or incongruous.
So they want to look at congruence of the complexes. So you're thinking about MI. Okay, all right, but it's not an acute presentation. You could CT his head. Everyone gets a CT of their head, and they get ceftriaxone, don't they, and a CRP and a troponin. So yeah, you could do a CT of the head. What would you be? Are you subarachnoid? Yeah, looks possible. So all of those things are possible, but I guess this guy's walked in. It's it's a month post. So it's great to sort of work through all of those things. Obviously, as with all of these things, I've got a sort of cut through kind of message. So one is a left bundle and syncope is automatically a high-risk patient for cardiac syncope. And if you look at studies of bundle branch block in patients presenting with syncope, the probability of it being arrhythmic once you've excluded other major pathology is astronomically high. And although there's no doubt the left bundle is associated with heart failure and cardiomyopathy and ischemia in this sort of age bracket, and you would go on and investigate for that stuff. If all you did was stick a pacemaker in, you'd probably get it right almost 3/4 of the time according to the stats, which is not bad odds. So it's not uncommon to see patients with left bundle who you work up, you don't find anything, but they're having syncope. In that setting, I think it's very reasonable to put in a pacemaker on spec, in essence, because that's a pretty good hit rate. And the last thing you want is the fractured NOF or falling through the bathroom sort of window. So I'll skip that. So back to football players, because I like football players. So this case was a nice one that was presented at the ESC maybe 2 years ago, I think. So young guy playing football, had a syncopal event on the football field, and as one of your colleagues pointed out, exercise-induced syncope during sport is particularly troubling. He's not doing drugs, he's not on a medication, he gets drug screening, all that type of stuff, looks after himself, there's no family history of sudden death, which is very important. Coach kicks him off to hospital. Flavour of the day, of course, still ECGs and a history, which is critical in assessment. Interested in your thoughts on this ECG if you saw this in your urgent care centre. Anyone? So what do you think of so there's ventricular ectopy, What do you think about where it's located? R on T. Great, fantastic. So that's a critical thing. So you remember the VEs from the other patient were quite discrete from the T wave. So this is I guess a classic sort of R on T VE, and you could just pick that up and go, a couple of VEs, pretty well, young guy, that's fine, we'll send him on his way. But in fact, this ECG tells you that this patient is at high risk, and so did the story. So those two key messages, exercise-induced syncope, abnormal ECG. So it's got, so these are what, short sort of coupling sequence really between the VPC and the T wave, which portends a high risk of ventricular arrhythmias. So I'll skip those. I guess, I'm sure everyone would now admit the patient. So let's move to see what happened. That's what happened. That's bad. This patient ended up obviously developing polymorphic VT. And you can see that in the changing sort of axis, that kind of flowing flowing pad. It's not quite, sort of not quite torsade, almost is torsade, isn't it? So that's sort of obviously very, very troubling and could result in death. So if we look at different forms of VT, just as a very sort of broad descriptor, monomorphic VT classically occurs with structural heart disease of various sorts with a particular focus within the ventricle, but it may be ischemic. Polymorphic VT, when you've got a normal QT, is often triggered by ischemia, and in a younger person you might be worried about anomalous coronary vessels, for example. Polymorphic VT with a long QT, you've got to really look obviously at the cause of the long QT, but the critical therapy to start instituting in that setting is IV magnesium. There are plenty of cases where people have seen VT and long QT and have given amiodarone and caused on more VT because they blow out the QT. So important not to make that common mistake. And it doesn't matter what the magnesium, you can pretty much, if you see it, you can just start giving high doses of magnesium. So in a young person who's had polymorphic VT, there's lots of sort of rare and intriguing diagnoses that we think about, including things like myocarditis, sarcoid, Brugada, right ventricular dysplasia, all those sorts of things. People can also develop it as just a primary electrical problem, and it really then falls into the domain for the EP cardiologist to look at. But as I understand it, and I'm not an EP cardiologist, that VEs that come from a focus classically within the Purkinje fibers can be quite unstable and often trigger this sort of pattern. Now, this case had a whole series of additional sort of complications with refractory VT and storm and getting ablated and so on and so forth. But I just wanted to give you that initial message about the ECG and the history. And you've already saved the patient's life because you didn't send them home, and you get them to the right centre for assessment. David, how am I going with time? Okay, cool. So I just wanted to finish off by talking a little bit about drug-induced long QT, because obviously, again, can cause sort of malignant arrhythmias and may present occasionally as syncope, hopefully not as sudden cardiac death, but can do. This is obviously torsade, the classic arrhythmia that complicates QT prolongation, and an important condition to try to treat and avoid, essentially. So QT prolongation was recognized up to maybe 100 years ago with, as a consequence of quinidine, but really started to become known in the 60s with quinidine, procainamide, and disopyramide as three key cardiac drugs that both caused long QT and were associated with VT. which eventually got recognized or described as torsade. In the 1990s, many of you will recall the issues with terfenadine and related antihistamines causing long QT and sudden death. And it's really in the 1990s and beyond where there's been this surge of recognition of QT prolongation secondary to drugs. And we've had antibiotics and a range of other medications increasingly recognized as causing this problem. And clinical trials in that era and onwards started mandating the assessment of QT prolongation as part of drug development and safety reviews. The Credible Meds is the kind of key kind of website where information about drug-induced long QT is held. I'm just curious, can I get a show of hands who's familiar with Credible Meds and who uses it? Look, I talked about this a few days ago with a group of psychiatrists and GPs in Melbourne. There's about 50 or 60 of them, and I got one person as well. So for the gold standard site that is free to access and that everyone's meant to use, it doesn't seem to have got its name out there very well, which is a bit unfortunate. Credible Meds is a US-based group, I guess. They're independent of pharma, and they're funded through grants, I think, from the NIH and the University of Arizona. They basically have a committee, a large group of people. They peer review all of the material that comes through. And they are the gold standard reference point now for all the warnings on QT prolongation with drugs. And it's the go-to kind of site. Initially started by covering mainly US drugs, but also now recognizes stuff that comes in non-US markets. These are just a couple of screenshots from the site. So, as I said before, you can register for free. They give you email updates on your drugs. You can search them. It's very easy to use. I was having a play with it the other day, and it categorizes the various risks of patients. They've got full sort of lists and links to PubMed and so on and so forth. So the QT interval is often vexed with measurement errors. So we often rely on the computerized measure, but that is frequently wrong. So it's really, really important that you all get used to measuring it if you're reading ECGs in your day-to-day urgent care sort of setting, which I'm sure you are. So the definition of QT prolongation is more than 450 milliseconds in men and more than 470 milliseconds in women. And there are a couple of methods of measuring it. But in essence, it is from the onset of the QRS, or so the onset of the Q wave or R wave, depending on what comes first, and the end of the T wave. And the tangent method is probably better regarded than the first, but either is good. And essentially what you're doing is taking a tangent of the steepest part of the T wave slope and intersecting that with the T wave baseline. And that is the measure of your QT. And you should do measurements from a few leads. V5 and V6 are often quite good. And if you do 3 or 4 and average them out, that's a pretty reasonable way of doing it. But you can imagine that computers and computer algorithms can easily get this wrong. And you may find you need to repeat your ECG a few times to get a clearer and easier to read trace. If you've got a lot of motion artifact in it and movement, it's going to be hard to read, and you're going to get it wrong. There's just an example of a corrected QT of 5-10 milliseconds in a hypomagnesiemic patient. These things are obviously important to recognize. So there are formulas to correct for heart rate. As heart rate goes up, QT should shorten. As heart rate goes down, QT will lengthen. All the formulas are reasonable. It's sort of said that the Zetz formula, one at the top, doesn't correct so well when you get a heart rate over 100, and maybe the other correction is a little bit better. But in essence, on a lot of the apps like MD Calc and all the rest of it, you can put these in your phone and they'll help you calculate according to different methods. So when does QT prolongation really become an issue? Anything with a 500 plus, increased risk of malignant arrhythmias. The other thing is to look for a change in the QT. So something that goes up by 60 to 70 milliseconds from whatever the baseline for the patient is also portends a higher risk of torsade. And the cellular sort of mechanisms that kind of drive that are due to abnormalities in the potassium currents that help to repolarize the T wave. But mechanisms are not fully understood. So Credible Meds has a risk categorization. So there's known risk, possible risk, conditional risk, and risk associated with in the congenital long QT syndrome. Essentially, known risk patient or known risk drugs are ones that will cause long QT and torsade in normal dosing, whereas conditional risk will usually cause long QT but not clearly seen to cause torsade in recommended dosing. Conditional risk requires some additional factors, and additional factors might include other drugs that prolong the QT, or metabolic derangements like hypokalemia or hypomagnesemia, whatever it might be. So there are a range of factors that can play in. I've put a couple of lists up here. These are not exhaustive drug lists by any stretch, but highlight some common drugs that cause long QT. And on the left, with the known risk group, you can see amiodarone and sotalol. We bandy that round like lolly water, along with azithromycin and various other things that we use. And these things are quite strongly associated with long QT and torsade. And given the volume of patients getting it, there are potentially many thousands of preventable deaths due to these drugs. So I sort of urge you to sort of always keep these things in mind. You can see from this graphic highlighting the surge in the number of drugs that are potentially issues for long QT and torsade, particularly in the last sort of 15 to 20 years. And this graph, which I also thought was interesting, that the cardiovascular and mental health space, which certainly are dominant areas that we all look at, these drugs have a high propensity to cause issues. So always think about other factors that would play in. All the hypos will contribute, so magnesemia, calcemia, and kalemia. Bradycardia increases it, and patients that have developed renal dysfunction, been put on diuretics, have underlying heart disease, and so on, are going to be at higher risk as well. So you should always consider that when there are drugs at play. Think about your drug interactions and changes in the clinical state of your patients. And I think the other thing to remember is it can be quite idiosyncratic. So you can have a patient that's been stable on, say, flecainide or sotalol or some such thing for a long time, and at some point down the track may blow their QT and develop torsade. And that's true with the psychiatric drugs as well. So I think some vigilance is required, and regular ECGs for these patients is important. I thought this was this paper from Jack, so I think you guys get the slides, but it's a nice summary of that whole kind of area. It was just published a few months ago or last year. And it even talks about handheld QT monitoring devices through smartphones being on their way. So there's lots of technology that might come forward that might help us in managing our patients. So sort of conclusions, I think if I can get back to basics, the history is really, really important in any patient that you assess with syncope. Drilling down on the story, the timeline of events, the circumstances, and really trying to work out the diagnosis. And I would suggest to you that about 90% of the time, you can make your diagnosis on a history alone. And as part of risk assessment, it's that history, the exam, and the 12-lead ECG will cover you for the vast majority of cases. And you want to focus on that stratification. Am I dealing with a low-risk patient who can go home and be assessed in time by their regular doctor, or am I dealing with a high-risk patient that needs admission and potentially more specialised assessment? So I'll stop there, and if there's time, happy for questions.